Thank you. So we're just trying to create a small summary, an algorithmic approach to treating AMD. It's too vast to cover, but we'll just go through these points. So we'll be discussing the diagnostic, the initiating and propagating treatment, and evaluating prognosis. So in diagnosis, do we really need, this is just the opposite, do we really need to see the retina now to make a diagnosis of OCT, AMD? The answer is actually no. It's a textbook pattern recognition diagnosis. This is just one simple controversial slide. So at the point of diagnosis, how does the algorithm work? We'll check about location, type, location foveal or non-foveal or threatening the fovea. That depends on how aggressively you need it. The type, basically, is it a pre-RP or a post-RP lesion, or is it so extensive that you cannot make out? The activity, is it currently active? Is it overtly active? That's a new concept. Is it a smoldering disease that is coming off and on and going, or is it totally inactive? Is it a variant? Is it a typical type of AMD, or is it a variant of AMD? The many variants we see. What is the duration? Is it a new disease, or is it a reactivation, or is it chronic? So this is how to align your thought process basically in a patient with AMD at the point of diagnosis. So the type 2, 1 and pre-RP, post-RP I'm not saying, but if you see something like this, you see a mound, you see a lot of intraretinal changes, a lot of hemorrhages. As I said, even if you don't look at the color picture, you get indications that this is a type 3 CNVM. And here, when you see this, I have got this in the wrong place, but let's skip that now. Now coming to initiating treatment. So these are the headings I'd like to discuss under. When do you start immediately? When would you defer it for some time? If you have a typical AMD and you have signs of activity, which are cystoid macular edema, obviously SRF, hemorrhage, you would start treatment immediately. But when would you defer? If you have nil activity. So what do you mean by that? You're putting it under AMD, but you're calling it nil activity. You're calling it a non-exudative CNVM. That is, it is an OCTA diagnosis. Looking at the picture, there is no CME, there is no hemorrhage, but on the OCTA, you see a subretinal network. So you have a non-exudative. It is not inactive. It is not exuding. That's all. And it's a CNVM, a non-exudative CNVM. So that is your first criteria where you would not treat, where you would just observe the patient. These are other pictures here. You see the network. You see a slight double layer sign over there, and the OCTA picks up the membrane, non-exudative CNVM. And on a closer, it looks like a very frilly, lacy kind of membrane. So these are just pictures of the same. We'll just skip this and coming to. So a non-exudative CMVM is a type 1 growing laterally, not invading the RP in a potential space, and that's how it doesn't exude. What is important is the last line. Up to 15% can convert to an active CNVM in the next 1 year. So that is the importance of diagnosing a non-exudative CNVM. So next, when you have minimal activity, would you defer initiation? So this is an example. You have sub-RP activity. The RP PED is expanding, but there is no SRF. So for all practical purposes, you could label this as minimal activity. There is sub-RP activity. There is not enough SRF or CME to justify anti-VEGF. Anti-VEGF could also hasten towards atrophy if you treat it in these patients by a sudden collapse of the PED. So this would be the second circumstance where you defer treatment a little bit. And then the next circumstance, non-neovascular SRF. You have SRF, but it is not neovascular in nature. 3, if you have fluid on top of the PED, if you have fluid at the edges, the draping of the PED, or you have a blanket between two PEDs, this is called non-neovascular. So these are the examples. On the left-hand side, A, you see fluid at the apex of a PED, but it's stable, it doesn't change. On the second one, you have a drape that is between the two bumps of the PED, you have a small amount of SRF, and the third is at the edge. So these are the 3 examples of non-neovascular SRF. You are not justified in treating, you can observe. So there's no network in OCTA, but you have the 3 examples of non-neovascular SRF. The next, if you have a doubtful diagnosis, initiating treatment. Here you have elevation, you have a lesion, it looks like, but this on the FAF, you see it hyper-autofluorescent. So this is vitelliform. This is a vitelliform hyperfluorescent autofluorescent. It looks like a CNVM, but it's not exactly. These are the images that came earlier, so not supposed to be there. Hyper-autofluorescent. And this is a differential diagnosis also. Anybody can guess what this is? This is what it looks like on, this is not SRF. This is what you call a torpedo maculopathy. The diagnosis is torpedo maculopathy. It looks like SRF. It is non-neovascular. It's just like a broad FCE kind of picture. So once we start treatment, you go to how intensive you are. So I like to say that you have less aggressive features and highly aggressive features. The two less aggressive features would be the presence of subretinal fluid chronically without intraretinal fluid and the presence of multi-layering. And the highly aggressive features will come to that. So multi-layering is supposedly a less aggressive feature. Why? It doesn't bleed, it doesn't rip. The fluid stays for a very long time, the vision is maintained for a very long time, but on the flip side, it does not respond well to anti-VEGF, which is false. It responds greatly to the current anti-VEGFs. That is when the really powerful ones, the multi-layering goes down nowadays. This is another example having laminate. You see the laminate inside the PED. Laminate bodies are the same thing. These are good, comparatively good prognostic. You don't have to be highly aggressive with the anti-VEGF. So these are two indications: multi-layering, multi-lamination, and the presence of subretinal fluid alone. You can tend to be a little less aggressive with your anti-VEGF. This is one example where you have to be less aggressive, not because of any other reason. You might cause a severe rip if you are highly aggressive. Persistent SRF. There is nothing called happy fluid or beneficial fluid. There is nothing called beneficial fluid. There is only tolerable fluid. How much can you tolerate? Defined at 200 microns. Why? If you treat it too aggressively, it's not like fluid is good. The photoreceptors are bathing in fluid happily. It's nothing like that. If you treat fluid too aggressively, it will go into atrophy. That's the reason why it is tolerated. And why it is called tolerable when there is no change in visual acuity. You have a stable visual acuity, stable amount of fluid. Again, indication for less aggressive treatment with anti-VEGF. So the two treatment modalities, we call PRN and TAE. I would say reactive, because in PRN you are reacting. When you see edema, you are reacting to it. When you see SF, you are reacting. So it's a reactive therapy. And it is escape for disease control. When you have disease, it indicates that the condition has escaped the control and you're reacting to it. Proactive is maintaining disease control. You are not allowing the fluid to come. You're giving an injection before the fluid actually comes. So one is proactive. That is, when you do a TAE, it is a proactive treatment. And the aim of AMD is not to treat the OCT, it is to prevent long-term drop. The worst thing that can happen to you is not presence of fluid, it's the presence of atrophy. So the whole indication, the mindset should be changed that you don't over-treat chronic SRF. So this is the hardest thing. Starting treatment is easy, continuing treatment is easy, but knowing when to stop treatment is one of the hardest points in management. So the ability to stop is when you have stable SRF, when you accept activity with stable SRF, when you see outer retinal tubulations, when it goes to multi-layering, or when you have an end result of extreme RP atrophy, and that requires you to become less aggressive to maintain vision. So this is an example of persistent fluid. You have the fluid, there's no change in the sub-RP activity, the fluid is stable, you can afford. The time is your biggest weapon you have. No? You can wait, you can watch, and we don't use that weapon sometimes. Or when you see degenerative edema, that is thin-walled cyst, when you see it, you know that it is not because of activity, it is because the RP barrier has been broken and you have transudative fluid. So that is sensation. Now, this is when you have to, any recurrence of a PED has to be considered as reactivation. It's a very, very simple point. You have a flat thing, but when the PED rises again, activity is coming again. Now, let's look at prognosis, a very big slide. Prognosis depends on location. Prognosis depends on nature of the disease. Whether it is a typical AMD, you've caught it extrafoveally, you've treated it, or is it a variety like RAP, where you're going to struggle with treatment and may end with RP atrophy, or is it a disease like PCV? Of the many varieties, some respond well to anti-VEGF, some don't respond well. So this is some of the large things that don't respond well, and SHRM. SHRM or SHRM is hyperreflectivity material inside the SRF. Why is it dangerous? Some SHRM disappears. Some SHRM remains. It's just so we're calling it the wrong thing. The SHRM that remains is actually cellular tissue, which gets converted to fibrotic tissue. So when we see SHRM, and under each visit it doesn't go away and it becomes more and more compact, you know it's just something becoming a scar. And that will result in poor visual acuity. So this is the SREM, and when it goes, you see it's still over there. It becomes more and more compact, and then finally you end up in a scar. Multi-layering, as I said, and when you see a scar, you have to assess how to stop treatment, where to stop treatment. You can have two. A scar with activity, that is you see true activity, or a scar with degenerative changes. So here you see a scar, you see fluid on top. You could treat aggressively, but if you look at it, it's very thin-walled. It's persistent. It's not changing. This is degenerative cystoid macular edema on top of a diseased retinal pigment epithelium. So aggressive treatment of this is not required. It's just for your satisfaction. The background RP, the amount of geographic atrophy around the CNVM would dictate how aggressive you would be. You can afford to preserve the RP by being less aggressive if the following features, you recognize degenerative CME, you recognize SRF, and you say, let me take a step back and let me not treat this aggressively. The choroidal features. Some of the leptochoroids are the most dangerous diseases to treat because they go into atrophy extremely fast. So identifying a thin choroid, a leptochoroid CNVM is very, very important. So all these features are imaging-based features, diagnostic, prognostic. It gives you features to say things. So the end result, just listen to this please. The end result of AMB, the end result of PCV is not scar, it's actually atrophy. So all our efforts should be to prevent atrophy happening in all these changes, and that is the most important thing. Thank you.
Thank you, Unni, for the overview of the algorithm approach for AMD.